Welcome to the deep dive. For you, as a high-level professional in assisted reproductive technology, we know you navigate complex patient decisions every single day, especially when it comes to that intricate challenge of endometriosis-related infertility.
It's a constant challenge.
It really is. So today we're diving deep into a question that is not just critical, but, well, often fiercely debated in our field. Does pre-IVF surgery truly improve outcomes for women with endometriosis?
That's the million-dollar question, isn't it? And to tackle it, we've compiled, a pretty comprehensive stack of the latest sources, everything from narrative reviews, cross-sectional studies, right up to large-scale meta-analyses.
Good.
Our mission today is really to meticulously unpack this evidence, weigh the often conflicting viewpoints, and pull out those key insights, the ones that can genuinely enhance your tailored management strategies in clinical practice.
Absolutely. Think of this deep dive as your shortcut, helping you discern precisely when and why surgical intervention might be considered, or perhaps more importantly sometimes, avoided
Yeah,
before starting an IVF program. It's all about optimizing those patient outcomes.
exactly.
So let's get right into it.
Let's do it.
Okay, let's start with the basics. Endometriosis itself. We understand it as this chronic, estrogen-dependent inflammatory disease.
Yeah.
Endometrial tissue outside the uterus. It often leads to chronic pelvic pain and, crucially for our discussion, infertility.
Right.
What I find particularly striking is its complex pathogenesis. I mean, we're talking local hypoestrogenism, progesterone resistance, a highly pro-inflammatory microenvironment. It's a lot going
It
on.
really is. And it's this chronic inflammation that creates such a hostile environment for fertility. You've got inflammatory mediators in the peritoneal fluid directly impacting oocyte quality, impacting release.
Yeah.
Then you have adhesion formation. That can severely distort pelvic anatomy, tubal function. And of course, ovarian endometriomas, OMAs, they can be devastating for ovarian function. They create this incredibly toxic environment full of free iron, reactive oxygen species.
Leading to oxidative stress.
Exactly. Significant follicular damage. It's almost like a systemic attack on fertility in many ways.
And the timeline for these patients is often so difficult, isn't it? That average delay in diagnosis, 7 years.
Staggering.
When you think about the combined effect of disease progression and the patient's age on ovarian reserve, that delay can severely compromise a woman's chances. It feels like a race against time for many.
It absolutely is. Which brings us to management. Currently, the landscape offers sort of two main paths for endometriosis-related infertility: IVF or laparoscopic surgical excision of the lesion.
You have two big options.
Yeah. The challenge, though, is that the data often gives limited, sometimes conflicting guidance on which way to go or when. It just highlights the absolute need for individualized treatment strategies. You have to base it on the patient's wishes, symptoms, age, couple preferences.
No easy answer.
Definitely no one-size-fits-all solution here.
Okay, let's unpack this further, starting with ovarian endometriomas, OMAs. These are common, found in up to 44% of women with endo. And we know they significantly impact ovarian function, ovarian reserve.
Right. Clinically, you see it. Reduced AMH levels, lower antral follicle count, AFC. It's that toxic inflammatory soup inside the cysts doing the damage.
So the surgery question for OMAs,
Mm.
this is where it gets really interesting. Potentially practice-changing even.
Yes, this is a critical point. Multiple systematic reviews, meta-analyses, they provide really solid, consistent evidence. Surgery for endometriomas. It does not improve IVF outcomes.
Not at all.
No. Not live birth rates, not clinical pregnancy rates, not even oocyte retrieval numbers when you compare it to leaving those OMAs untreated. That's a major finding we really need to absorb.
That is a powerful statement. It forces a reevaluation, doesn't it? And maybe even more critical is the risk surgery poses to the ovarian reserve itself.
Huge risk.
Cystectomy, the technique we've often relied on for pain and recurrence, it consistently leads to a drop in AMH levels, a big drop.
We're talking an average of 38%.
Wow, 30% for unilateral, but a striking 44% for bilateral cases.
Yeah.
That's not just a number, it's real damage, isn't it? Accidental removal of healthy tissue, vascular damage from coagulation, inflammation.
All contributing. And for patients needing repeat surgery, the cumulative effect can be devastating for their reserve. It's a trade-off that often doesn't favor fertility.
So connecting this, you mentioned a recent study. Sinoni et al.
Yes, very recent, 2025. It's retrospective, so we need to keep that in mind, but it offers a really compelling finding. It suggests that IVF performed before endometrioma removal surgery, they called it IVF OPS, actually yielded better clinical pregnancy rates.
Better how?
Significantly better. 50% versus about 26%. And they also saw an improved number of top-quality blastocysts compared to doing surgery before IVF, the OPS IVF group.
That's fascinating.
It really suggests that, for OMAs at least, surgery might be better timed after the oocyte retrieval. Get the eggs out first, then deal with the cyst.
A potential paradigm shift for some cases.
Yeah.
So given these risks of reserve and this new kind of counterintuitive data, how do we guide patients? When is surgery for OMAs still clearly the right call beyond just IVF numbers?
Excellent question. It highlights the nuance. While it might not boost IVF rates, surgery is justified in specific situations. Think severe pain impacting quality of life, pain that doesn't respond to medical treatment. That's a big one. Then there's the practical side, improving follicle accessibility during retrieval, especially for large cysts, say over 4 centimeters that are just in the way.
Makes sense.
Also, if ultrasound features look suspicious for malignancy, obviously, or sometimes to prevent cyst rupture during a pregnancy, which can be a serious issue.
So it's about addressing immediate risks or severe symptoms, not a default for a fertility boost. And when surgery is done, do the techniques matter for reserve?
Oh, absolutely. Technique choice is paramount. Cystectomy is common, but newer techniques like CO2 laser ablation or plasma energy are generally seen as more tissue sparing.
Less collateral damage.
Potentially, yes. They seem to cause less damage compared to, say, bipolar diathermy, which has a higher risk of thermal injury. So the bottom line for OMAs, it's a careful balancing act. Weigh the benefits against the risks to reserve, always factoring in the patient's starting ovarian reserve. It has to be individualized.
Right. A true risk-benefit analysis for each patient. Okay, let's shift gears now. Deep infiltrating endometriosis, DIE, and superficial or peritoneal endometriosis, PE. DIE is the really severe form, right? Posterior compartment, often involved intense inflammation.
Exactly. It creates this highly inflammatory peritoneal microenvironment that definitely affects fertility. But the evidence for pre-IVF surgery for DIE, it's quite conflicted. That's a major point of debate.
Still no clear answer?
Not really. There's a real lack of good randomized controlled trials directly comparing surgery versus no surgery before IVF. Though, it's worth noting there are 2 ongoing RCTs, EndoFert and SPHEDO-E, trying to fill that gap.
Okay, good to know.
But looking at existing studies, some, like Bianchi et al., or the Casals meta-analysis, they suggest that extensive DIE excision, especially colorectal DIE, can lead to higher implantation and pregnancy rates or better IVF outcomes.
But that's not the whole story.
Far from it. Other significant work, including meta-analyses by Capel, Borden, and others, found no significant difference in IVF outcomes with or without prior DI surgery.
No difference at all.
And some, after they excluded studies with high risk of bias, even suggested a significantly lower live birth rate with surgery.
Lower, wow. That really highlights the uncertainty and why this is so tough for clinicians.
Absolutely. So given this messy picture, the key recommendation right now, based on what we have, is pretty clear. Surgical excision of DIE should not be offered first-line in asymptomatic patients just to improve IVF outcomes.
Why not?
Because the risks of major DIE surgery, things like ureteral damage, bowel leakage, are serious. Plus, it causes significant delays to starting fertility treatment. The risks often outweigh unproven benefits for IVF success alone in those asymptomatic cases.
Okay, that's a crucial distinction. Asymptomatic and fertility is the only reason. So when is DIE surgery indicated then?
Typically, it's reserved for patients with intolerable pain symptoms, pain refractory to medical management. Treating the pain can, of course, improve well-being and maybe even a natural conception chances for some. And it's absolutely crucial to intervene surgically to address or prevent severe complications. Things that could blow up during IVF stimulation or pregnancy, like bowel occlusion, subocclusion, or hydroenterate or hydronephrosis.
Urgent situations.
Exactly. And maybe, just maybe, for women who've had multiple failed IVF cycles, extensive DIE excision could be considered a sort of last resort, but again, carefully weighing those significant risks.
Understood. Okay, what about superficial or peritoneal endometriosis, PE? The less invasive kind, but still linked to infertility through inflammation. What's the surgical role there?
Well, laparoscopic management can sometimes enhance natural fertility, spontaneous conception, but specifically in appropriately selected symptomatic cases. Removing lesions, dealing with adhesions might help mechanically. But, and this is a really crucial caution for practice, current guidelines and evidence strongly advise against routine laparoscopy in asymptomatic and fertile women just to look for and treat potential PE.
Why is that caution so strong?
It comes down to the numbers. The number needed to treat, the NNT. To get one extra pregnancy with surgery for PE is pretty high, somewhere between 12 and 40. Compare that to an NNT of around 4 for IVF.
Big difference.
Huge. So for PE, surgery is generally unlikely to improve IVF outcomes specifically. The literature just isn't there to recommend surgery for PE, mainly to boost ART success. It's a different calculation than managing significant pain.
Right. So if we try to tie all these threads together,
Yeah.
the overarching principle that just keeps emerging is nuance. It absolutely demands a highly personalized approach for every single patient with endometriosis-related infertility.
That's the absolute cornerstone, yes. You have to weigh so many factors. The patient's desire for pregnancy now versus later, the presence, the severity of pain, critically, the specific type, location, extent of the endo.
And patient factors, too.
Absolutely. Age, ovarian reserve, AMH, and AFC are vital here, and adjusting strategy based on AMH is common sense, really. History of previous surgeries. We know repeat surgery is generally bad news for the ovaries. And you can't forget other infertility factors, like male factor. It's always a comprehensive picture.
And underlying all of this, the surgeon's expertise seems paramount. Minimizing trauma, maximizing outcomes, especially with delicate ovarian tissue involved.
Critically important.
Now, considering that endo itself, and sometimes the surgery for it, can harm ovarian reserve. What about fertility preservation? Is that becoming more central?
It's becoming an increasingly vital consideration, yes. Fertility preservation, mostly oocyte freezing, makes a lot of sense, especially for younger patients. Also for those with bilateral endometriomas, ideally before surgery, or anyone with a history or high risk of multiple surgeries, or even just reduced reserve to start with.
What's the goal there?
The goal is proactive protection. Protect the ovarian reserve from potential surgical damage and secure future reproductive options for that patient. It's about giving them more choices down the road. Empowerment, really.
Okay, so recapping this complex journey. For ovarian endometriomas, it feels like the newest data, maybe like that Sinishi study, is hinting at IVF before surgery as potentially better for pregnancy outcomes. A fascinating shift.
It is. And for DIE and PE, the main takeaway is surgery isn't typically recommended just to improve IVF success in asymptomatic women. The risks are too high, the benefits unproven for that specific goal, but surgery absolutely remains crucial for debilitating pain or preventing serious complications.
Right. Different indications. The unifying thread, though, through all of this seems to be the absolute necessity of personalized, evidence-based care. As leading RD professionals, your role demands that holistic view weighing immediate pregnancy rates, yes, but also long-term ovarian health and patient well-being.
It's about empowering our patients with the most informed choices possible, based on the best, albeit sometimes complex, evidence we have.
So, here's the final thought for you to consider. As professionals dedicated to expanding reproductive possibilities, how do we best integrate these evolving, sometimes really counterintuitive insights into our daily practice? How do we ensure every patient receives not just evidence-based care, but the truly personalized path to parenthood that's right for them?
That's the ongoing challenge and pursuit, isn't it?
It certainly is, something that will undoubtedly continue to drive research, clinical discussion, and our collective pursuit of excellence in this field.